Hi, I'm Darryl, and I'm sitting with Rob, who's a genetic counselor, and he's sitting from his home, as we all are. So, Rob, genetic counselor, I mean, not many people know what that is. I
Right.
barely know. Why don't you just let's dive into that?
Sure,
And
no problem.
and the reason we're talking to you before you dive into that is that at Malecare, we think genetic counseling should be part of the team of specialists that you approach around your prostate cancer treatment. And many people come to us, both newly diagnosed, advanced stage, and stuff, and they're wondering how to get better understanding of the state of health, the state of their tumor, whether or not their tumor is going to kill them or not tomorrow versus 10 years from now. So genetic counseling is one of the specialties that sort of is the pathway to finding out. And what we're going to talk about today is how to use your tumor cells, how to use the biopsy that's already been taken out of your body when you were first diagnosed, and make that a critical part of your discussion with your doctor. So, Rob, what do you do for a living?
So I'm a genetic counselor by training, meaning I have a master's in genetic counseling. My first job out of grad school, I worked as a genetic counselor at Memorial Sloan Kettering here in New York, seeing patients who were affected by or at risk for hereditary forms of cancer. At that time, it was mainly breast cancer, ovarian cancer, colon cancer. Obviously, we've identified more tumors that can be hereditary in nature since then, but I mainly focused on breast and ovarian cancer at that point. I would talk to a patient about their family history, about their cancer diagnosis, about their treatment plan, and then we would take a blood sample and send it to a laboratory called Myriad Genetics in Salt Lake City. And now for about the last 17 years, I work for Myriad Genetics, and my role is to really provide education for physicians. If you think about it, a lot of physicians went to medical school before genetics became a big thing, and so rather than going back to school and learning about it, they rely on people like me to help them understand which are the patients that are appropriate for testing, what it means when they get a test result back, et cetera. So I do more education and support for physicians.
So today, there probably are very few physicians listening to this. It's
Hmm.
probably several thousand men and women who are either diagnosed with prostate cancer or struggling with one of their loved ones
Hmm.
around prostate cancer. So let me promise the audience this is not going to be a doctor to
Right, right.
doctor kind of presentation. So the idea, so hereditary prostate cancer, I mean, we've all heard, like, if your uncle or your dad had prostate cancer, you ought to get checked more often than not, or sooner
Hmm.
rather than
Hmm.
later, compared to somebody who hasn't. How does that relate to the idea, and what is hereditary prostate cancer?
Sure. Well, let's just start with most cancer is not hereditary. Most cancer just happens by chance and as an effect of like aging or just by chance. Then there's a certain proportion of cancer that we call familial, meaning that it there's more cancer in a family than we would expect based upon statistics, but still no real genetic marker to identify those patients. But then around between 10 and 20% of cancer we call hereditary. And that means that there is a genetic marker, a change in one of the genes that we all carry that then increases the risk for developing cancer and then also can increase the risk for that cancer to be more aggressive. So it's
So,
about 10 to 20%.
so when you say 10 to 20, I mean, are you saying 10 to 20% of all cancers, or 10 to 20% of people diagnosed with prostate cancer?
Uh, 10 to 20% of people diagnosed with prostate cancer, but also other cancers that are tied to prostate cancer. And this doesn't sound like they're tied together, but if you think about, for instance, the BRCA1 and 2 genes, a lot of people call them the breast cancer genes, but they increase the risk for a woman to develop breast cancer and ovarian cancer, but they also increase the risk for men to develop male breast cancer and prostate cancer. So there are clusters of cancers that go together based upon which alteration or which gene has an alteration.
So a man with breast cancer, male breast cancer person, are you saying that if you have male breast cancer, you're much more vulnerable to having prostate cancer?
So male breast cancer, a pretty significant proportion of male breast cancer patients will have a mutation in one of the BRCA genes, so BRCA1 or BRCA2. And so, yes, those genes also increase the risk for prostate cancer.
Okay. And, as our audience knows, I mean, Malecare has been running male breast cancer support groups since 1998. We're one of I think we are the first organization in the world to do that. I guess that's about 22 years now. The idea, so many of our guys come to either prostate cancer support groups and eventually get dual diagnosed with another type of cancer, or many of the men in the breast, I wouldn't say many, but a portion of the men in the male breast cancer support groups who enter, in their 20s or 30s, tend to navigate into a prostate cancer group later on. So thank goodness they're available for them through the spectrum of their disease. I don't want to get too much into BR this or, BRCA that. I want people to have, and I want to have, just a very simple wordplay to have with my doctor about what it is that I want to find out, how I can find that out, and what are the pros and cons of trying to find that out.
Okay.
So when we talk about genetic testing, which is really what we're talking about. What actually, is it a blood draw? Do I have to go under anesthesia and, have my guts pulled?
Yeah, so it's a very easy blood draw. We can also do testing via saliva sample as well. So it's just, you go and get your blood drawn for PSA or for any of your other CBC or, any of those other normal tests, and it's just a normal blood draw that then it gets sent to the laboratory.
So the genetic testing is different than the kind of testing that's done on the biopsy?
Yes.
What would you call the testing that's done on the biopsy?
Tumor tissue testing. I mean, there are biomarkers that are available that look at the DNA and the RNA of the tumor itself. We look at the blood because these are hereditary, so they're in every cell of the body. They come from either our mother or our father. And so we can look at the blood and pull out the DNA and be able to determine whether there's an alteration or not. We all have all of these genes. It's just a matter of whether there's an alteration in one of them or not.
So DNA, that rings a bell because there's DNA in me or whatever, 23andMe and all these other products.
Sure.
So why is there, I'm guessing, a hospital-based test is more accurate than one I could get on Amazon, but am I wrong? What's the difference between something that just requires me to spit into a tube and send it out in the mail versus what you're describing?
Sure. So some of you mentioned 23andMe. Some of those, what we call direct-to-consumer genetic tests are really what we call recreational genetics. They're going to tell you, where your ancestors are from. Are you German or are you African in descent? Some of them will also tell you, whether you have wet earwax versus dry earwax, or whether you have markers that could make you be able to twist your tongue in different directions, etc. So those are more fun. Those are more like, let's talk about this at a party sort of types of things. Whereas this is a genetic diagnostic test where we're looking at specific genes that we know increase the risk for cancer. And that can be done in several different situations where we're testing somebody who doesn't have cancer yet, but has a strong family history. So if you think about Angelina Jolie, she was on the cover of Time magazine a few years ago because she had a mom with breast cancer and an aunt with ovarian cancer. And so she was tested for these exact same genes that we're talking about. No cancer yet, but she was found to carry one of the mutations that gave her about an 80% risk for breast cancer. And so that's why she had her breast removed. So in some situations, we can either prevent cancer or detect it when it's in a very early, more curable stage. And then once someone gets cancer, we can determine whether or not it's hereditary or not, which can, affect the way that we're treating the cancer.
So let me catch up with you.
Okay.
Are we talking about going to our doctor and asking our primary care doctor, our internist, our local general practitioner, or local GP, Marcus Welby perhaps, or whoever it is. And just for the audience, I truly never watched the Marcus Welby TV show, but I'm familiar, I know it existed. So the idea, are we just saying, all right, do a PSA test, but also do a genetic test?
If you have enough of a family history, then that is certainly a possibility. These tests are mainly for individuals who have a strong family history or who have a cancer diagnosis themselves.
Okay. So that sounds suspiciously like all the conversation about should we wear a mask or not wear a mask? Should we get a COVID test or not get a COVID test? I mean, isn't it sort of like a common sense thing? I mean, if the guy is, or woman who's your doctor is got a needle in your arm and drawing blood, why not just take a few extra drops and everybody get a test?
Well, because first of all, it's an expensive test. It is covered by health insurance for those individuals who meet certain criteria, but we want to make sure that we're targeting the individuals who this could actually help. And so for instance, somebody who doesn't have a cancer diagnosis and doesn't have any family history, it's not really a test that's appropriate for them because they don't meet those criteria. There are medical criteria that some of the professional physician societies have put together as to who is the most appropriate for genetic testing.
Okay, so that's a conversation to have with the doctor.
Right. Mm-hmm, sure.
So when you talk about appropriate, there's also concern. I mean, are tests appropriate for, let's say, gay men and prostate cancer, for African American men, for men of African descent, for Caribbean American men? Have these tests been tested or validated or verified for men other than white men?
Yes, absolutely. I mean, if you look at at all of us at the DNA level, we share more DNA than we differ. And so we've actually, Myriad Genetics in the past 25 years since we discovered the BRCA1 and 2 genes, we've tested now about 3.5 million people of all different ethnicities and backgrounds. So yes, it has been validated across all of those groups.
And would black men, since black men have prostate cancer disparity prostate cancer kills, I think now 2.4 something or other, 2.4 or 2.5 times as many black men as it does white men. I mean, does that give a higher imperative for black men to have this blood draw and have this kind of genetic testing?
So that's a very interesting question. There's been a lot of questions about whether, because there's more prostate cancer in that community, are they more likely to carry a mutation in one of these genes? And what most of the research has shown is that it's pretty similar across all ethnicities, the likelihood of carrying a mutation. It is a little bit higher in the Ashkenazi Jewish population, but in other populations, it's pretty much the same across the board.
Okay, so we take this test. What's it going to tell me?
It's going to tell you if you have an alteration in one of about 35 genes that we look at that are involved with the 8 most common hereditary cancers. So breast, ovarian, pancreatic, prostate, colon, endometrial, melanoma. I missed one in there somewhere. But you get the point. It's the 8 most common hereditary cancers. So we look at 35 genes.
Okay, so is it something, and so you look at those, a piece of paper comes back. I mean, does the results come to the patient or to the doctor?
The results go back to the ordering healthcare provider, whether that be the physician or a nurse practitioner or a genetic counselor, whoever is the one that orders the test, and then they will sit down and discuss the results with the patients.
So what might that discussion look like?
Most of the time it's going to say, hey, there was a reason why we ordered this test for you, and it came back negative, and that's good news. About 10 to 20% of the time, it will come back with an alteration where the physician will say, okay, well, you have an alteration in this gene, and that means this. and now we're going to treat you differently. It's all precision medicine, being able to identify ways to treat patients based upon their genetic results.
So precision medicine is something
Mm-hmm.
that
Yeah.
we've been talking about for 5, 6, 10 years or so. But for a patient, it's hard to sort of translate that into something practical, because there's still the conversation. Uh, my biopsy came back positive, or my PSA is high or elevated. So I got prostate cancer. So what's the conversation about? Surgery, radiation, or active surveillance? I've got advanced stage prostate cancer. What's the conversation about? Estrogen deprivation
Mm-hmm.
therapy, or one of the new approaches, or some. I mean, none of this sounds precise yet. What actually is genetic testing doing to sort of push that towards genuine precision?
Okay, so if we have someone with localized disease, for instance, very early stage prostate cancer, if we do a genetic test and we find out that they have alteration in one of the BRCA genes, like we talked about, we know that that cancer is more likely to be more aggressive. And so that might be somebody who the physician would say, you know what, we had thought about active surveillance for you, but because of this genetic marker that tells us that your cancer may be more aggressive, we're going to go ahead and take that off the table. We want to, go ahead and treat you. In the case of somebody who has a disease that may have spread to other parts of the body, then we're looking at a conversation where it may be, you have an alteration in one of the BRCA genes, again, because they're the most common. And we now have a new class of drugs that is specific to patients who have these BRCA mutations and sort of targeted, I guess. So precision medicine in that way.
Well, it sounds like yay.
Yeah,
Now we
it's
have,
very exciting.
yeah, and for both sort of classes of men, newly diagnosed and advanced stage guys. But we're still talking about 10 to 20% of the total
Right.
prostate, which is, when we're talking about on a scale of millions, I mean, that's nothing to discount. I mean, that's like good news that we got something to
Mm-hmm.
help tens of thousands of people, and it just requires drawing some blood. Those of us with thin veins will shudder at that, but most people, yeah, I've been poked way too many times
Yeah, I don't like
without
having my
success.
blood drawn either.
Right, but I don't like having a biopsy,
That's
and
true.
I really don't like dying. Not that I've done that yet, but I mean, so blood. I mean, it's like it's got some good information, and these tests apparently provide an added layer of information that could sort
Mm-hmm.
of parse out or help us make decisions. Would you say that, like, for 10 to 20% of men, for where these genetic tests actually have some genuine value, it could actually make it could be like the deal maker between doing an aggressive treatment versus active surveillance?
Mm-hmm. Absolutely, certainly, yeah. Because again, like I said, if somebody has an alteration in a BRCA gene, they may have a very localized prostate cancer, but at some point that is more likely to become aggressive. And so we'd rather get ahead of the game and go ahead and treat that individual, take out the prostate rather than just watchful waiting or the active surveillance and just wait for it to blow up.
And could this test be used to sort of, for most guys present in sort of a middle ground, Gleason 3-4, Gleason 4-3, elevated PSA, if not quite 10, maybe 6, 7 or so. So like, it's sort of like, it's really the doctor's game, how much fear to put in that person or not, and it's the patient's game, to question the doctor, to have a genuine conversation of what life is really about from the patient's point of view. Do these tests have the degree of, not accuracy, but sort of confidence to help make that decision for the patient?
Mhm. Yeah. So like I said, we've been doing this for about 25 years. We've tested 3.5 million patients at this point. And it is covered, I mean, it is recommended by all the professional societies. It's covered by Medicare, covered by most insurance companies. So the science behind it, we've written thousands and thousands and thousands of peer-reviewed, scientific articles about it. So, we do have a lot of experience with that. Not to say that we're not still learning. We're still the greatest thing about genetics is that we're still learning new things every day. And so, we may come back 10 years from now, or scientists may come back 10 years from now and have identified a whole new set of genes that we would then add to the what we call the panel of tests that we do. So,
Yeah. And like, how long so like the blood gets drawn,
mhm.
how long does it take to get a result back?
We guarantee through about 3 weeks, but usually it's less than that.
Okay. So a length of time, but not an
Hmm.
insane like
No,
year or two later. But
no.
it is like 2 or 3 weeks, let's say, maybe earlier. I mean, who knows what it is these days and for the next, through 2021 until things settle down a bit. But the what is there any sort of concern around anxiety causing initiated by asking for one of these tests?
Yeah, so there hasn't been as much research done in men who are getting genetic testing, but in the beginning, we weren't sure about women who were getting genetic testing. If they found out that they had a mutation, was that going to cause depression? Was that going to cause anxiety? So there was a lot of research that went into that in the very beginning, let's say back in the early 2000s. And what researchers found was that these tests don't actually increase the anxiety. They don't cause depression. Most individuals who are getting these results are using the results to empower their own medical decisions. And so it's seen more as empowering rather than anxiety ridden.
And for those guys who have families or spouses
Right.
or partners, I mean, how did they sort of, I mean, do you have a sense of when you speak with men and their families and partners and spouses, how they sort of react to the idea when you suggest or talk about a genetic test?
Sure. So it's interesting, and maybe it shouldn't be interesting to me because I've been working with a lot of cancer patients over the last 20 years. But when we're talking with men with prostate cancer, what they're really concerned about is their daughters, because these are the same genes that causes breast and ovarian cancer. They're concerned about their daughters. Do I have something that I could have passed on to my sons or my daughters? And so a lot of the time that the men are getting this information, it's also to help with the family members' risks.
Okay. So, like I have a 7-year-old son, should I have him tested?
No, so we don't recommend testing for minors because we don't see a whole lot of minors getting, breast cancer or prostate cancer. So even if somebody has a genetic alteration, their offspring can be tested, but we usually wait until they're an adult and
All
can
right,
make their own
but
decisions.
this sort of raises an interesting thing. So, like, I've heard the term and used it probably incorrectly more than not, the germline versus somatic line.
Hmm.
Somatic refers to, well, I'll let you explain. What's the difference between germline and somatic?
So germline is what we look at in the blood, and that's what we inherit from our parents. Whereas somatic is the tumor tissue, the genetics of the tumor tissue. And so once somebody develops cancer, the genetics of that tumor sort of evolve over time, especially as it gets more and more advanced. We find more genetic alterations within there. So if you have a germline mutation that you've inherited from mom or dad, that would be in the tumor because it's in every cell of the body. But then there are some additional genetic alterations that can happen, as that cancer is growing and progressing.
So it could change for the next generation. Is that what you're saying?
No, so that those types of mutations that are occurring just in the tumor cannot be passed on to the next generation. Only
Excellent.
the germline mutations. Yeah.
So yeah, so the idea is that, I mean, like tobacco abuse, working with nuclear radioactive materials, those kind of things, environmental things. They,
Right.
screw our bodies up and in some cases create tumors. Farm workers, agricultural workers, people out in the field, migrant laborers, they have a high incidence of cancer
Hmm.
because they're exposed to fertilizers
Right.
firsthand. They're literally breathing it and touching it. The people who worked in military, Agent Orange is, an instigator of cancer
Right.
by all accounts. And it's not just Agent Orange for veterans, it's also fuel oils, unexploded ordnance, exposure to chemicals in fabrics and protective materials that protect you from one thing but harm you in another way.
Right.
All of these are, start or instigate what are called somatic tumors.
Right.
But what we're talking about in these blood tests are the germline, which is, by the way, do we know why it's called germline?
I don't know the answer to that. I've thought about that several times. Um, but just when we're talking about egg cells and sperm cells, they're called germ cells. And so, the germ line then is the line of cells that come from those eggs and sperms.
Right. And germination, I mean, the word
Right.
germ
Yeah.
has this extraordinary history and root.
We think
Uh,
about germs a lot differently nowadays, but
yeah,
yes.
yeah. So the idea of um, knowing genetic lineage, the genetic consequences of having mom and dad and my grandparents creating mom and dad and my great grandparents creating my grandparents and on down to my kid and eventually whatever he does breeding wise, the idea of looking at how uh, DNA, looking at how genetics influences the development of various cells in the body. So once again, why would, since that's not going, that sort of signaling is not changing, as we get older,
Mhm.
why not find out about it from, I mean, maybe not birth, but certainly whenever a child has blood drawn, I guess as a teenager when it's, not going to create massive crying, why not do genetic testing at that point?
Yeah, it's just, we, even in families that have germline mutations that run through them, we want those children to have a normal childhood. We want those children to be able to make their own decisions about whether or not everybody wants to know their genetic status. And so it's really just recommended that we wait until somebody is the age of majority. Plus, it's not really increasing their cancer risk until they're an adult either. The only difference to that is, we do see some cancers that are younger in age. So I had a patient who was 23 when she developed breast cancer. And so the screening recommendations for somebody who has a first degree relative is to start screening 10 years before that cancer. And so for somebody who has a cancer in the early 20s, for instance, then we might consider testing their teenage children just because we would need to know whether to start screening those individuals. But most of the time, it's not really important to know until you're at the age of majority.
Yeah, very good. So let me sort of repeat back in 45 seconds or less
Okay.
what it is we've talked about, and correct me if I'm wrong, because if I didn't get it, then perhaps I failed to properly inform our audience. So there are these tests called genetic tests. Your patient and doctor requested from a company like Myriad.
Hmm.
And Myriad is, what is it, Myriad?
Myriad. Yeah.
And do you know where that name comes from?
Um, I'm not actually sure why they named it Myriad. I think just we talk about, a myriad of things happening. So I think I don't know whether that was the intent. That was made, long before I started working for the company. Yeah.
Yeah, I mean, I think Subaru actually has one of the more interesting name heritages that I've found. I mean, it's really interesting how companies brand themselves. The idea of being able to draw blood, find out for 10 to 20%, for like a fifth to a quarter of men, with, just men, whether or not you have the kind of prostate cancer that's more likely to kill you than not. And that kind of information for people who are just popping into their doctor's office and perhaps meeting a urologist for the first time in their life, that kind of information can help you decide whether or not you need an aggressive early treatment, which may in fact help you to live longer, but impacts your quality of life in such a way that it really challenges you around erectile dysfunction and urinary continence and all these other things. Okay, so you have the ability to sort of do a better than average guess, sort of really a genuinely informed choice making around what kind of early stage treatment you need or you desire, or you'd rather set aside until something proves out in the future that maybe you should get something, or that you could die from something other than prostate cancer, or as we say at Malecare, our success is measured by you dying from prostate cancer at age 120. Right. So the idea of that's a good thing. So am I correct so far?
Sure, yes.
Okay. And then the second benefit or another benefit for guys who are basically seeing an elevated PSA after an initial treatment, or they're newly diagnosed with a high grade, high Gleason score, prostate cancer, and most of those guys are young African-American men, and they get information from that same kind of blood draw that helps them identify treatments that they may not have known, or their doctors may not have been aware would be really effective for them.
Correct, yes. Yeah.
Okay. And the downsides are just expense, it sounds like. I mean, the 2 to 3 week waiting period, not great, but I mean, it's not hellish. And for some people, support groups or talking to friends and neighbors, or just watching Netflix for 14 straight days, whatever it takes to sort of get through that waiting period, the gold at the end of the rainbow is available to you in the results of this kind of testing. Yeah. And so again, it's the only significant downside is expense. So what does that mean for like Americans, and what does that mean for men worldwide?
So for Americans, we do most testing on Americans. This testing is covered 100% by Medicare. So they have identified that these are valuable tests that give valuable information for men with prostate cancer, and so they covered it 100%. Most other insurance companies also covered very high. We find that about 75 to 80% of men have 100% coverage. And if an insurance company doesn't cover 100%, usually the out-of-pocket is less than about $50 or $53.
And so you said Medicare, but what about for younger men?
For younger men, so the other commercial insurance is right. So if you meet the guideline criteria and you're identified as being an appropriate candidate for this test, then most of them covered at 100% as well.
Okay, so not too big an out. Well, let me ask you it this way: who are the men who are not covered?
So the men who are covered are men who have Gleason 7 or higher with a family history, or any metastatic individual. They're all covered at 100% usually. So the ones that are not covered at this point, I'm sort of waffling because things are changing this summer. With the approval of the PARP inhibitors in July, we're starting to see already, just even a month and a half later, that the criteria for testing is opening up, and more people are getting coverage. For instance, Medicare sent us a letter saying that now any individual who is or may become eligible for a PARP inhibitor is covered. So we're starting to see, just like we did with some of the breast cancer and ovarian cancer patients, the criteria is starting to open up and allowing this information for more people.
So let me repeat back that. For Americans, there's probably a way to pay for this.
Yes.
For Europeans, in general, for people in the European community, and who knows what's going on in Britain, but what would you say to them?
There are laboratories that do it in Europe. We will take samples from Europe, but they, they would have to pay out of pocket, basically.
Okay, and I guess that goes for pretty much everywhere else in the world.
Right.
Does that go also for Canadian men who
Yes.
aren't that far away? Ah,
Yeah.
That's a shame. And Mexican
but again,
there
are laboratories there that do similar testing as well.
Okay, but Mexican men as well. I mean, North America. It's not a North American kind of thing. It's an American thing.
Right.
Okay, and okay, well, this really, really cool. Now I feel up to speed on this. Thank you.
Sure.
All right. So I'll see you around, and hope you stay safe. And
yeah, stay safe, stay healthy.
Yeah, 6 feet safe.
Yes.
That's what we're saying. All right. Take care.
Okay.
Thank you.
Bye-bye.
Thank you. Bye.